Good afternoon, everyone. I'm Dr. Angela Hind, and I'm the Chief Executive here at the Medical Research Foundation. So today's public science seminar is about the biggest health threats that we face, those of drug-resistant superbugs, known to some as the challenge of antimicrobial resistance, or AMR for short. So I'm absolutely delighted to be joined today by a doctor and a scientist whose career the Medical Research Foundation helped to launch through our PhD training program in antimicrobial resistance. Dr. Wezi Sendama is a clinician-scientist based at the University of Newcastle, and he is here to talk about fighting superbugs and the research on lung immunity that he's working on. I'd be delighted, Wezi, if you could introduce yourself to our audience in your own words. So over to you.
Thank you very, very much for the kind introduction, Angela. As Angela says, I'm Wezi Sendama. I am lucky enough, partly because of the generosity of the Medical Research Foundation, to be in a unique position to have a dual role. One part is as a medical doctor. I look after patients with respiratory illnesses as a consultant in respiratory medicine at the Royal Victoria Infirmary in Newcastle. And I also undertake medical research, looking at ways to improve lung immunity at Newcastle University. So this is where I work. This is the Royal Victoria Infirmary. It's a large hospital. It's a large city hospital, and you will have hospitals like this close to where you live. And in my role as a medical doctor, I get an insight into the things that go on, what the administrators would count as the regular business, the regular tick over of the hospital. And the sorts of things that happen day to day in a hospital are things like elective surgery, say, for example, knee or hip replacements or abdominal surgery for cancer operations or to fix hernias, or maternity, young babies being born. And then on the less elective side, you've got emergency things, so emergency presentations. So I have an interest in respiratory medicine, and about 30% of presentations to the emergency department are for respiratory reasons, most of those being infections, so things like pneumonia, or injuries also present to the emergency department. We take a lot of that for granted. We take a lot of that activity for granted, and it just ticks over. But the overwhelming likelihood is that none of that activity would be possible without antibiotics. And an important thing to say about antibiotics is we don't use them just in clinical practice to treat infections. We also use them in all of those scenarios that I just talked about to prevent infections. And so talking about a routine operation, for example, if we had antibiotics that became less and less effective, not only would there be an increased risk after the infection from picking up a secondary infection that occurs after the treatment is complete, but also not being able to use the antibiotics to prevent infections would mean that all of the operations become a lot more risky. And as Angela would have alluded to, the thing that I'm referring to that makes antibiotics less effective, that has been making antibiotics less effective, is the concept of antimicrobial resistance. So antimicrobials in general refer to the drugs that we use to treat bacteria, to kill bacteria in the main, but can also refer to the drugs that we use to kill fungi, which can cause infections, or viruses that can cause infections. And antimicrobial resistance arises partly because bacteria cause problems because they replicate, and they replicate quite quickly, and our immune system tries to get rid of the infection by eating the bacteria and isolating them from the rest of the body. But if the bacteria are replicating faster than the immune system can do that, that can cause an overwhelming infection. Each time a bacterium replicates, it has to copy its genetic code. And antimicrobial resistance arises in part due to that. Each time the genetic code replicates, there's a small chance that the genetic code has a mistake in it when it replicates to form the next bacterium, the next copy of the bacterium. For the most part, that has no significance at all. In some cases, you can have a mistake in the genetic copy that is harmful to the bacterium, so it dies out easier. But every now and again, you might have a mistake in the genetic code as it copies, which makes it more resistant to the antimicrobials, the antibiotics that we use. What that then means is that if you have an antibiotic that treats a colony of bacteria, for example, and a proportion of the bacteria have become resistant, what that then means is the ones that don't die out, that are resistant, can replicate then and are resistant to bacteria that you try to use again. And that is one of the things that contributes to making antimicrobials less effective. And that's not just theoretical, that is something that happens in practice. That is something that is here with us now. And so you'll have news headlines, and you will be aware of news headlines referring to antibiotic resistant bacteria. This one tells of, like we were mentioning, routine hip surgery that is now complicated by the development of an antibiotic resistant infection. Somebody has died after contracting an antibiotic resistant infection in an intensive care unit. This is another one about an antimicrobial resistant bacterium that has resulted in the death of a patient here. Another death of a patient by an antimicrobial resistant bacterium called MRSA that you might be aware of. And high-profile cases like protracted infections with MRSA from the actress Leslie Ash. And the question becomes, well, this is very obviously a health threat. This is very obviously a serious problem. What can we do about it? And at policy level, we think about attacking it from several different domains. We can have a think about whether we are diagnosing infection correctly, because in a number of cases we use empirical antibiotics. We use best guess antibiotics for suspected infections when patients present with the signs and symptoms of infection. Part of the reason that we do that is because the risk of missing an infection, the risk of missing the opportunity to treat an infection is great. But what that means is that we don't have a 100% success rate in diagnosing infection. Sometimes we get it wrong and we could have gone without the antibiotic. So the development of rapid diagnostic tests to tell us what type of infection we have, what antibiotic might be best used to treat that infection, if so, and at what point to treat it. Being able to diagnose infection more accurately will help us use our antibiotics more efficiently and reduce the risk of antimicrobial infection, antimicrobial resistant infection. There is an angle of attack that focuses on targeting the use of antimicrobials in agriculture, and the farming sector is a large user of antimicrobials. And as I learned during my PhD and where I got to network with people that worked in the farming sector, the use of antimicrobials in farming means that animals are able to grow with reduced risk of infection. But what that then means is the antibiotics are in the water supply, which gives an increased opportunity for those antimicrobial resistant bacteria to form. The other thing, and I guess my hook, is having a think about the research and development of new therapeutics, new antimicrobials, or in my case, actually medications that are not antimicrobials at all, that might improve how we use antibiotics, reduce the use of antibiotics, and make people able to fight off infection a little bit better. And the angle I come at it from in my research life is informed by my clinical work. So in my clinical work, I look after people with respiratory conditions, including respiratory infections. And respiratory infection, pneumonia chief among them, is again a large global problem. It's the fourth largest cause of death globally. And one of the things that we see about respiratory tract infections like pneumonia is that they become you become more susceptible to respiratory tract infections as you grow older. As well as that, they're likely to be more severe as you grow older. And also, as you grow older, your something changes in how you deal with infection, such that if you were young and you contracted pneumonia, you're likely to recover without too many ongoing effects. If you're over the age of 65 and you contract pneumonia, you are twice as likely to die in the subsequent 10 years. You're more likely to bounce in and out of hospital with recurrent infections. And in my research life, I do a lot of thinking about why that might be, what happens to the immune system that you're less able to fight off infection after you get a pneumonia, what happens that you're more susceptible to pneumonia after you get an infection. And most of where that stems from is the body's response to infection. Maybe there's something about that that changes as you get older, that means you're more susceptible to infection. And the primary process that characterizes the response to infection is called inflammation. And that's a generic response both to injury and infection, depicted by injury here, but equally applicable to infection. And what happens is that pathogens like bacteria are introduced to a space where they're not supposed to be. And the immune system, of which a very important part is immune cells that circulate in the blood, white blood cells that circulate in the blood. They move to the site of infection to, in a sense, eat the bacteria, to wall it off away from the rest of the body to reduce the chances of the bacterium spreading, and then start the processes where the injured part of the body or the infected part of the body can heal. And a lot of what we think about is whether we can alter this process, we can alter inflammation in a way that makes people more likely to be able to combat infection. And so we focus in our lab on the function of white blood cells. They're depicted here eating these blue particles that are meant to represent bacteria. But what they do when they sense and encounter bacteria is they engulf them and they break them down. And that's after they've moved from the blood to a site of infection. Another curious thing happens as you get older, in that we note, particularly in the lungs, and this is a graph from a study looking at the lungs, that even when there is no infection, as you get older, you can detect larger and larger numbers of those immune cells that are supposed to move from the blood to the lung only at times of infection. But when there is no infection, as you get older, you find greater and greater numbers of those white blood cells, neutrophils, in the airways. It's really not clear why that is. So inflammation should be something that happens when there is injury and infection, but we recognize that as people get older, inflammation, a chronic low-level inflammation, starts to set in. And so my particular interest is in the resolution of inflammation, because when those white blood cells move into the lung, they're supposed to undertake a process where the resident immune cells in the lung signal to the neutrophils from the blood to say, there's no infection here, you don't need to come to the lung, there's nothing to fight. But something seems to go wrong with that process as you get older. So my main research questions were, is the persistent lung inflammation a failure of resolution? And that's important, partly because those white blood cells that attend from the blood to go to the lung to fight off whatever infection might be there, they contain toxic chemicals, partly so they can break down any bacteria that they eat. But if they're not cleared away safely, if the inflammation doesn't resolve in a safe an orderly manner, those toxic chemicals can leak out into the lung. They can cause damage to the tissue of the lung, which means that you're more likely to get a subsequent infection. You're more likely to get persistent inflammation, and the white blood cells that attend to fight off any further infection aren't working in the way that they should do. Second question is, can we find a medicine to fix this chronic inflammation of aging that seems to arise? And so the main thing that I set up during my PhD was this immune challenge study, and with the rationale that in order to figure out what might be going wrong with the processes of the start and the end of inflammation as you grow older, we need to be able to simulate inflammation in a controlled fashion. And what we did was we isolated part of a common bacterium called LPS. And what that is the signal that the body uses to tell it that there are some bacterium around. So we didn't use the bacterium, but we used the signal from the bacterium. And we used that to trick the body's immune system into responding as though there is infection. And what that then meant was that we could use a clinical technique that we use called bronchoscopy, where we pass a fiber optic endoscope into the lung to retrieve samples of the immune cells that have attended in response to the LPS. And we could simulate in a safe way what inflammation looks like in the lung and start to observe what it looks like as it resolves, both in young people and old people, and try to compare and see what the differences might be as you grow older, to try to understand it, to try to develop medications to treat it, to treat the persistent inflammation as you grow older. And so in the process of my investigation, as things went on, we set up this immune challenge study. We started to get samples through, and to take you back to 2020, we started doing this. We started doing these experiments in 2020, and shortly after we started, all of our experiments shut down. So we were told, you must stay at home. There's a circulating respiratory virus that is causing respiratory failure in people. It seems to be a virus that spreads quite quickly. We don't have any treatments for it at present, and so really all we have at the moment are non-pharmaceutical interventions like staying at home. Unfortunately, I work in respiratory medicine, so I couldn't stay at home. I went instead back to clinical work. And while at the height of the pandemic, we were seeing lots and lots of people with chest x-rays like you see on the left. For comparison, if you don't look at lots and lots of these chest x-rays, for comparison, I've put a normal chest x-ray on the right, and you can see the heart shadow right in the middle. You can see the rib cage and the spine, and you can see the lungs that are darker because they're full of air, and you can see right through them with the x-rays. On the left, you can see that the darkness of the lungs has become fuzzy, which is the pneumonia. That's the immune cells that have filled into the lungs to try to fight the virus, to try to fight the infected cells by the virus. And the immune cells and fluid have filled the air spaces, and that's what causes the main part of the problem. You can also see that the person on the left is very unwell. You can see that they've got lines and tubes attached to them. So we were seeing lots and lots of chest x-rays that looked more like the one on the left than the one on the right. One of the very useful and very interesting things that came out of the pandemic was how quickly we mobilized globally as a research community to find treatments for this previously untreatable new virus. And you'll remember the results of the recovery trial from news headlines, where it was recognized that a drug called dexamethasone, which is a drug that has been used in clinical practice for a very, very long time, a steroid, was effective at reducing the risk of death in people with COVID-19 that were unwell enough to require supplemental oxygen. And two things in particular were important about this discovery. The first is that steroids had been tried lots and lots and lots of times for severe respiratory failure, and all of the clinical trials had been negative up to that point. The second thing was that dexamethasone is not an antimicrobial at all. And the way that the steroids function in this case is as immune modulation. They changed the way the immune system worked such that people were able to survive and fight off the virus. Their immune system was able to clear away the infected cells, the cells that were infected by the virus, and allow them to recover. So two things. This was not an antimicrobial, this was an immunomodulation drug, and it was a drug that had existed for quite some time, that had been unsuccessful for similar indications before. So as things settled down and the waves settled down and a vaccine came into play, I returned to my research and had a think about my old question. In people who are older and their immune systems are, they've developed a low-level chronic inflammation, is there a way to develop a drug or repurpose a drug that settles down the chronic inflammation of aging? One of the ways in which drugs are tried is you have a large library of drugs and you treat a large number of cells from human samples and just see if any of them works. That's an expensive process, and there has been a push recently to have a think about whether you can use computational techniques to improve the quality of that process before you go to do your expensive experiments. So what I did was I had to think about the processes that we expected to be normal in young people and the processes that we had observed to have changed in older people when looking at their lung immune cells from the samples that we had. And from that, I was able to work backwards to through a large computational library and figure out which drugs I expected to have an impact on the capacity of the resident lung immune cells to resolve inflammation, to send out those signals to the neutrophils from the blood to say, we don't need you here from the blood, we don't need you in the lung, you can stay in the blood, there's no infection, you can settle down. And in doing so, I was able to identify a number of drugs, some of which had been used for different indications in the past, some of which have been tried as anti-cancer drugs, but crucially, some that have been tested in humans. We know that they're safe in humans, that can be repurposed, which keeps the cost of further development down, to enhance the resolution of inflammation in older people such that they're less susceptible to infection in future. And so I've identified those candidates, and I'm really, really pleased to say that I was awarded a research fellowship to be able to take that forward and start to test those medications on samples from patients and be able to recruit patients, older patients who have survived pneumonia, and see if we could improve the function of the immune cells from their lungs, such that we might be able to take those drugs forward to clinical trials to see if we can improve outcomes for patients after pneumonia. And what that then means is that those people, after they've survived pneumonia, are less likely to pick up further infections. They're less likely to return to hospital. They're less likely to be treated with further antibiotics, which means that there are fewer opportunities for antimicrobial resistance to occur, which means that we are all safer because the prevalence of antimicrobial resistant bugs is lower. That's the aim, that's the hope, and that's what I'm planning to do over the next few years. And so I do have to say a big, big, big thanks to the Medical Research Foundation for funding the initial experiments, for funding the PhD that formed the basis of my further work. Thanks to Newcastle upon Tyne hospitals that host the clinical portion of the work, the Medical Research Council that fund my fellowship and the ongoing work, and the NIHR Newcastle Biomedical Research Centre that are currently funding the infrastructure that supports the work. And that's a relatively dated photo of some of the people from the lab that I'm really grateful and pleased to work with every day. So if people have questions, I'm more than happy to take them. Thank you.
Wezi, thank you so much. What a fascinating presentation, and a real privilege to hear from somebody whose research is so directly informed by the patients you see in hospital. I would also like to say a personal huge congratulations to you for winning that very prestigious Medical Research Council clinician-scientist fellowship. This is really very well done.
Thank you.
So questions from our audience. I'm sure you've got lots of questions, so Wezi, are really fascinating. You may have questions about his research on chronic inflammation in lungs in aging, or generally about antimicrobial resistance. Do pop them into the Q&A. I'll read them out. We're not publishing the questions for confidentiality reasons, but I'll make sure that they reach Wezi. So whilst I wait for some questions to come in, can I ask you a question, Wezi? As a member of the general public, what's the most important thing that we can do in our daily lives to help tackle antimicrobial resistance?
That's a great question, and I guess part of it comes down to the statistic that I brought up earlier on, that if we're thinking about presentations to hospital, fully about 30% of those emergency presentations are related to respiratory illnesses. And I think even the stuff that doesn't come to hospital that's dealt with in primary care, a very large proportion of that is respiratory, and everybody will know it. Things like coughs, colds, or things that feel a little bit more that go to the chest, like bronchitis. The overwhelming majority of those, as people have started to appreciate, are caused by viruses. And I think it's important for people to seek medical attention when they are unwell, but also to appreciate that in a large number of cases, you can get away with those being treated as self-limiting illnesses and not illnesses that need antibiotics necessarily to treat. And that's part of our approach to good antimicrobial stewardship. In what situations do we really need to use antibiotics? And if we appreciate that most of the causes of respiratory tract infections are not likely to require antibiotics, are likely to be self-limiting, one of the things that we can do as the general public is to appreciate that that might be one of the outcomes of a consultation, and to use very simple measures that most people can do at home to treat those infections after seeking appropriate medical advice. Antibiotics aren't always the answer. The answer in a lot of cases, but they're not the answer in all cases.
Okay. And so I know people in my family who, even when they're prescribed antibiotics, they refuse to take them because they're worried about driving antimicrobial resistance. Is this wise?
I think if you are prescribed an antibiotic, that's on the basis of the information that a clinician has to treat a diagnosed infection. And I think on an individual level, if you've been prescribed them, the right thing to do is to take them and to take the course to completion. There's work from our centre that's ongoing about whether we absolutely need to run antibiotic courses for the durations that we do. And if we don't, then we might be able to shorten the courses of antibiotics that people take. We don't know the outcomes of those studies yet. And so the best thing to do is to take the courses of antibiotics that you're prescribed. You don't need to worry about causing antimicrobial resistance on an individual level. Those things are more at a population level than anything else. And the most important thing is that you're treated appropriately and that you get better.
Okay, thank you. I've got a question here from a member of the audience. So this is from Katie. She works in policy. Do you have any thoughts on what is required at a policy level to protect us from antimicrobial resistance?
At policy level, yeah, well, that's another really good question. And I guess as someone with an interest that I've already declared, I think research is incredibly important. I'm privileged to work in an environment where I see people trying to tackle antimicrobial resistance in a number of different ways, and we've got excellent research going on in terms of antimicrobial stewardship, as I've just mentioned, the trial to determine whether people need to take antibiotics or to be prescribed antibiotics for as long as we traditionally have used them, in diagnostics, in better tests to determine when antibiotics should be used and what antibiotics, and things like my own research into immunomodulation. Can we use the immune system better so that we can get away with using less antibiotics? So I think research, being able to support research is important at a policy level. And I think the other thing which I think has exploded over the time that I've been qualified, but it remains important, is education, making people aware of these things, making people aware of the challenge of antimicrobial resistance, and being able to push resources in that direction as people start to appreciate how serious a problem it is, not just in this country, but globally.
Yeah, yeah. So we've got a question from Stephanie. Stephanie said that she was interested to hear you talk about using antibiotics as a preventative measure in hospitals. Could that be contributing to and driving antimicrobial resistance?
Almost certainly. We try to limit the impact of that by using the lowest dose of antibiotic that you require. The way that we use them for in prevention, we call them prophylactic antibiotics. So we try to use the lowest dose antibiotic that we need to for the shortest duration that we need to, and the narrowest spectrum antibiotics. So not all antibiotics are created equal. Some treat a larger range of microbes than others. And if we know, say, for example, in elective surgery, what microbes are likely to cause a problem after the surgery, we can tailor the prophylactic antibiotics that we use. That doesn't mean that those antibiotics aren't contributing to antimicrobial resistance. And on the scale that we use them for prophylaxis, just to get through those procedures that we do every day, those clinical incidents that we get through every day, the scale at which we do that means that they have to be contributing to antimicrobial resistance. So in a sense, with that being the regular business of the hospital, the regular tick over of the hospital, there is a bit of a clock ticking in the background, in the sense that if our research is unable to catch up to the pace at which microbes are able to adapt to the antimicrobials that we use, then those very simple procedures, those very routine procedures, later become impossible. So we are contributing, and in a sense, we have pushed the problem onto the back burner, but it's a problem that we definitely need to continue to tackle, such that those simple things remain simple and don't become complicated over time.
Okay. Dan would like to know if we have any idea or statistics to show how the ability of certain antibiotics to treat an infection have changed over time.
That's a great question. It's probably more a question for the epidemiologists than me. But the things that people do track are the identities of those infections. So when I was putting up those news stories about infections, you might remember the mentions of MRSA, and MRSA stands for methicillin-resistant Staphylococcus aureus. And you can track the prevalence of that, because whenever a culture of an infection is taken in hospital, the sensitivities are checked by the microbiologist, and it's determined whether or not the bug is sensitive to an antibiotic or resistant to an antibiotic. All of those positive results are tracked, and so you can see in particular regions and over time the incidence of resistant infections and where they pop up and in what sorts of situations they pop up and what antibiotics they are resistant to. that has definitely been increasing over time, and as well as being resistant to penicillins, we have over time developed newer antibiotics that are able to deal with penicillin-resistant microbes. But certainly over the time that I've been practicing, we have the incidence of microbes that are resistant to even those drugs. So things like beta-lactamase producing bugs and carbapenemase producing drugs. So those are bugs. Those are bugs that produce enzymes that break down antibiotics. The prevalence of those has increased even just over the time that I've been qualified. And so you can track those. The exact numbers I can't give to you because I'm not an epidemiologist, but certainly they have been increasing, and that contributes to part of that ticking time bomb of antimicrobial resistance that we definitely need to combat.
And are you seeing patients who've got problems with superbugs in your clinic?
Definitely. And the common ones will be with respiratory tract infections, where people have infections with bugs that are relatively common, that are recognized to produce respiratory tract infections, have been common causes of respiratory tract infections like Haemophilus influenzae and Streptococcus pneumoniae. But where you used to be able to treat some of those with amoxicillin, which is a basic penicillin antibiotic, you now have to treat some of those with a penicillin antibiotic plus an additional drug that combats the forms of those bacteria that have started to produce defenses against the penicillin. So we've started to use combination antibiotics a lot more. We've started to use antibiotics that we didn't use before, just for the infections that we have known have caused respiratory tract infection. And also in respiratory medicine, a really common use of antibiotics in our hospital in particular, because we've got a large center, is for people with cystic fibrosis. And those people have, for various reasons, lung damage, they get unusual infections, they require repeated and combinations and courses of antibiotics. And some of those are becoming more and more difficult to treat. Some of those are becoming more and more difficult to treat in a way that means that, say, for example, those patients with severe lung destruction might be eligible for lung transplant are no longer able to be transplanted because the infections can't be treated. So we see that more and more commonly in routine respiratory medicine practice and specialty respiratory, subspecialist respiratory medicine practice as well.
And when you're seeing patients who are struggling with these as a result of antimicrobial resistance, how aware are they that that's contributing to their problem? And do you have to spend a lot of your time as a clinician explaining antimicrobial resistance to your patients?
I think for some of the patients with chronic lung diseases, and some of the chronic lung diseases are characterized by repeated infections, and a lot of those patients are really quite clued up, partly because they have repeated infections and they recognize that the antibiotics that we use to treat them are different to how they used to be several years ago. We might be using different combinations of antibiotics. We might be starting an empirical course of antibiotics when they first get the signs and symptoms, but when the results of their sputum cultures come in, we are told, well, the sputum that they are, the microbe that they're colonized with isn't sensitive to the antibiotics that we used previously, and so we have to switch their antibiotics. And so people start to recognize that, and they are aware of things becoming more difficult to treat, or being treated with combinations of drugs that they weren't treated with at the beginning of their chronic illness. And so a lot of our patients with chronic lung disease are fairly clued into the idea of antimicrobial resistance. They become expert patients, if you like.
Mm-hmm, mm-hmm. So we've got a question from Layla, who I know works in comms. She wants to know, what are the most common infections today that are becoming harder to treat?
Mm-hmm. Well, ones that we see commonly in the hospital will be purely because of volume, respiratory tract infections, but also skin and soft tissue infections. And I've definitely seen that over the course of my career become difficult to treat. I'd mentioned MRSA. Staphylococcus aureus is a common bacterium that causes skin and soft tissue infections. And so you can probably imagine that if Staphylococcus aureus becomes antimicrobial resistant, if it becomes methicillin resistant as MRSA, as in that news story involving Leslie Ash, that is very problematic. People who have infections that would ordinarily be relatively straightforward to treat, requiring longer courses of antibiotics, longer courses of combinations of antibiotics. They stay in hospital for longer where they might not have needed to stay in hospital at all for treatment of a Staphylococcus aureus that was sensitive to penicillin. So skin and soft tissue infections, I definitely see in my general medical practice, and in my specialty practice, respiratory infections, things like pneumonia have become more difficult to treat, certainly in the decade or so that I've been practicing.
Okay, thank you, Wezi. So we've had some brilliant questions from the audience. Thank you all very much. Can I ask you one final one before we wrap up? Is antimicrobial resistance inevitable?
I think it's a good question. I think it's here with us now. We need to have a think about how we mitigate it. We need to have a think about how we try to drive past it. I don't think complete antimicrobial resistance is inevitable. I think I'm as I say, I'm privileged enough to rub shoulders with people doing fantastic research in combating antimicrobial resistance every day. And so I know that we're making progress. I know that we're going to be able to stem the tide. I think we just need that extra push to help us get over the line, to, like I say, to keep the routine stuff routine, to prevent it from being complicated.
That's an amazing answer. So more research.
I would say so. As a researcher, I would say so.
Great. Wezi, thank you. That was a great way to spend a lunchtime. On behalf of the audience, I'd like to thank you. I'd also like to say some further thank yous to those who contributed to our work on antimicrobial resistance. So our thanks go to the Barber Foundation, who supported Wezi's PhD research, and a further thank you to the Trusts and Foundations who supported our other students. So that was the Chellerham Foundation, the James Ellis Charitable Trust, the Michael and Anna Wicks Charitable Trust, and the PS Charitable Trust. So thank you for joining us to hear about this life-changing research that Wezi's doing. If you'd like to learn more about this work, please visit our website. And if you aren't already, do consider signing up to hear from us via email. That way you'll be the first to hear about future seminars like this one, research news and breakthroughs, as well as more about our ongoing focus on fighting superbugs and how you can support it. Research like Wezi's gets funded because of generous donations, including from some of you who are tuning in today. Thank you for your continued support. And if you'd like to make a contribution to funding life-changing research, please consider making a donation to the Medical Research Foundation. We'll email across a recording of this session over the next few days so you can share it or watch it back. And I really hope you have enjoyed this seminar. Thanks all, and thank you again, Wezi.